ever so much for the Academy to invite me to speak to you this morning, and for all of you for turning out on this lovely crisp day. And I hope that you're going to get a lot out of today. It usually is a fantastic day, I have to say. So I've been asked to talk, well, I think my title was Where Medicine Meets Science, What is a Clinician-Scientist? But I've changed it a bit because I'm a surgeon. So I've changed it to Where Surgery Meets Science, What is a Clinician-Scientist? And I guess one of the reasons I've done that is just to point out to you a little bit about surgical research. Now, this chap up here is Richard Horton. He still is the editor-in-chief of The Lancet. And nearly 25 years ago now, Richard penned an editorial in The Lancet that compared surgical research to a comic opera. So he told us that we had lots of questions but few answers, that surgical research generally didn't rely on clinical trials, and really, was there even such a thing as surgical research? And I guess that's probably coloured in some ways my career to try to prove this man wrong, who was one of our guests, wasn't he, in Adelaide, I think a few years ago at the Academy, a delightful man. But I think, you know, it does make you have a little think about what we do, and certainly has coloured some of the research that I've done. But I thought I'd sit back and introduce you first for a few minutes to myself, and maybe the first thing I'll say, and he's left now, but fun fact, John and I went to the same school, and I think that biology teacher was Mrs. Bear, because she taught me as well, so I haven't told him that yet. Anyway, I trained in the UK, as did John, so I went to the London Hospital Medical School, which was in the East End of London, the traditional area where all of the immigrants have always come over many hundreds of years. So an area with a little bit like Royal Melbourne Hospital in some ways, lots of very interesting pathology and a fantastic place to train as a medical student. I then went on to become an intern in the professorial surgical unit at Royal London Hospital, and that really set me on the career of wanting to be a surgeon. I loved doing surgery. I thought it was great fun, hard work. I didn't mind that, long nights, you know, doing neurosurgery. I think this was doing neurosurgery with this colleague of mine. We were 1 and 2 on call, God knows how many hours a week, but great fun. And then I decided that I better, as a junior doctor, after doing all of that, first get my exam. So I became a fellow of the College of Surgeons of England, and you can see this sort of strange 80s look, and God knows what that lady's looking at under my dress. But anyway, and then I thought, gosh, I need to start doing some research. And so I was very fortunate to turn up. I went to see a number of different people. My bosses at the time had friends around London, sent me to different people to think about different kinds of research. I went to the College of Surgeons and met a fabulous man who was a colorectal surgeon, and he said, would you like to do 3 years dissecting cadavers' rectums? And I thought, maybe not. So then I ended up going to the Royal Marsden Hospital in the Institute of Cancer Research in London, met a fabulous man called Mike Baum, who was professor of surgery there. And Mike said to me, well, for the first 3 months, just stop. Start talking with all of your colleagues in the labs, the other junior surgeons, and have a think. So that was us sitting in the sunshine, having a think with people who are now very renowned academic surgeons. But it was a great time to suddenly stop this busy career as a surgeon, young surgeon, and actually start thinking about research and thinking about cancer. And it was also a great place to have those initial trainings in how to be an academic surgeon or a clinician scientist, because really the combination of having an Institute of Cancer Research next to a cancer hospital was an ideal place to get those meetings of different minds. And it was the beginning of the era of molecular biology, so a fascinating time to start to learn a bit about science, as well as continuing to practice as a surgeon, as a young junior doctor. I then became a consultant in London in the late 90s at Middlesex Hospital and University College Hospital, which is right in the middle of London, just behind Oxford Circus. And you can see us all sitting there, and you can see the sort of sea of faces, not very many women in surgery at the time. Maybe we'll come back to that later. I think about 2% of consultants were women in general surgery at that time. But I had a great time there as a senior lecturer. But then as a family in 2000, we decided to move to Australia. I had a young son by then, and the beckonings of Western Australia, you know, beautiful blue skies, beaches, seemed fantastic. So I came over to become a consultant at Royal Hospital, and became initially associate professor and then professor of surgical oncology in 2002. And I think I was probably the only first woman to be appointed as a full professor in surgery at the time in Australia. And I was still in my 30s, so that was fantastic. Had a wonderful time in WA, I have to say, a great place to work, lots of interesting research going on, and a really interesting diverse population. But of course, after a while, you know, those white sandy beaches and blue skies get to you, so the temptation of coming to the glorious weather of Melbourne was just a little bit too much. So here I moved to Melbourne in December of last year, and I've been here since, and it's wonderful to be here, I have to say. As Ingrid said, I've been very lucky, I think, in my career. I've became a fellow of this fantastic academy in 2016. I've managed to do quite a lot of diverse research, which I'll talk briefly about, published a number of papers, even appointed Scientist of the Year in WA, I think about the same year, 2017, I think. But, you know, when I was asked to give this talk live as a clinician scientist, the first thing that came into my head was, oh, I'm not really a scientist, you know, surely I can't give this talk. How can I do that, you know? And I think that idea of imposter syndrome is something that we all have to get over. And I've actually put up in here, this is a gendered picture of imposter syndrome, because it is definitely something that affects women more than men, and affects many of us, I think, and even in clinical medicine. When I first arrived at the Institute of Cancer Research, you know, there were these really clever scientists doing things I couldn't even spell and didn't understand. And it took me a while to realize, oh, but at least I can take an appendix out and they can't. You know, that gave me a little bit of comfort. But we do need to get over this idea of imposter syndrome. I think it is something we all have, and maybe women more than men, and maybe surgeons more than others for those reasons I talked to you. And my job, I mean, I'm an oncoplastic breast surgeon, so they even make Barbie dolls named after us, you know. So we really do have to get over it. Anyway, I'm going to talk briefly about what a clinician scientist is, but perhaps my path has certainly not been the traditional one that you heard from John. Apart from starting at the same school, we've done very different ways of becoming a clinician scientist, and I really want to try to impress on you this morning that there are lots of different kinds of clinician scientists. There isn't one thing that fits the mold, and I'm sure all of you, if you're in this room, it's because this is what you want to do, and I'm sure you'll all get there, but you'll all get there in many different ways, and you'll end up being very different people, and not the same traditional thing. Now, this is the thing that people often think about, you know, the typical clinician scientist stereotype, and I can guarantee you this guy is an old American surgeon, isn't he? You know, with all these things behind him, looking rather grim and unhappy and grumpy there. And it's interesting in surgery, just to give you another anecdote, I do recall when I was a young surgeon, already a consultant, and I went to a meeting at the College of Surgeons in London, and I took my son, who was about 3 at the time, Tom. And there was this sort of sea of men looking very much like this, you know, looking at you over their half-moon glasses. And one of them patted Tom on the head and said, so, Sonny, would you like to be a surgeon like Mummy? And Tom looked absolutely aghast. And he said, oh, no, surgery's for girls. Well, I'm delighted to say he's now an academic historian in Cambridge, so he clearly hasn't gone down that route. And he still doesn't really think that we're proper academics in medicine. It's quite interesting when you get that view from people who are doing something completely different. So there are different paths and different ways. I think this guy is a great poster child for a different way of doing research from WA. So many of you will recognise Barry Marshall, who along with his colleague Robin Williams was awarded a Nobel Prize. And he really didn't go about his research in the same way that many of us would think. I'm sure you've all heard the story of Barry swallowing the H. pylori and proving that stomach ulcers were due to an infective cause, which has actually revolutionised surgery. I mean, no more do we do all of those operations for ulcers that we used to do when I was training, and it's due to people really thinking outside the box. So what is this thing, you know, called a clinician scientist? Is it always somebody who has a wet lab? Well, clearly not, and we need to think about all the different things it could be. But first I want to just tell you some of the attributes that I think probably you all need to think about, and most of us as clinician scientists have in reality. Generally, we are people who really want to innovate, to advance treatment and patient outcomes. And we're always asking questions. You know, whenever you see a patient, you think, well, why is that? Why is that happening? And particularly perhaps some of the complex clinical problems that are either ignored or thought, you know, too unsolvable by others. And we very much like to observe the outcomes of any experimental interventions, that's clinical trials, I guess, to further improve and innovate. You heard before the idea of becoming an expert in something, and I think you'll find that most clinician scientists, we really do have our one area that we understand a lot about. Now, it might be one disease, and you understand a wide variety of things over that disease, from the biology to the epidemiology to the outcomes of it, or it might be in one specific area of science. But generally, most clinician scientists will pick an area that they're really expert at, and they're known as that around the world. It's also really important for us to disseminate knowledge and expertise and train the next generation. The things I've put in red at the bottom, many clinicians who are not clinician scientists will have these attributes, but I think most clinician scientists will have these as well. They tend to be leaders in the hospital and the profession. You know, they tend to be people who are leaders within their colleges or their societies. They often, but not always, will manage a department, and I have to say that's probably one of the most depressing things we have to do, you know, the HR, budgetary responsibilities, but we all have to do it at some point. Often we're the people who advise government, and certainly our academy advises government on lots of different issues, and that's really interesting, as I'll talk about a bit in a minute. I've talked about leading societies and professional colleges, and also within the medical school we're often leaders. You know, we're often the people who do the curriculum development, and of course we're also the people who often talk to media about things, and you know, we've got some great examples in our academy talking to the media, for example, about COVID in the last few years. It's often the clinician scientists who'll be doing that. But you might think to yourself, oh my goodness, that sounds an awful lot of things to do. And maybe I should not bother with all that, and maybe I should just become a really good clinician. But I'd like to put to you that, you know, it is fun doing other things, influence a bit more than just the patient in front of you, and that's what we're here to do, not just influence the patient in front of you, but influence the whole of medicine and all of those patients out there worldwide with that condition. So what does it take to become a clinician scientist over and above being just a really good clinician? Well, I think using curiosity and intellect. Now, clearly good clinicians will do that as well, and skills of observing are important for all of us as doctors, and all of us want to do the best by our patients. But I think the real thing about being a clinician scientist is we take ideas, information and observations from the bedside, and then we actually go and try and do some work to work that out. And we'll either do that in collaboration with other people, you know, the scientists you know, and John talked about the importance of collaboration, or you may take it into your own lab, and that might be a wet lab, but it also may be an epidemiological question, or a question you're going to ask about very clinical outcomes. And you may have to learn a lot of new skills to do that, skills that are outside the normal skill set of a very good clinician. Also, the real key thing is disseminating that evidence. So the clinician scientist is the person generally who publishes, who goes to conferences and talks at conferences, who writes national guidelines on how to treat something, and is prepared to stand up and be a real leader in the field. What kind of research can you do as a clinician scientist? Well, all sorts of things, and I'm sure you'll hear today from lots of different people. So not just laboratory stuff, although that's really important, and basic science may be your thing. It may be translational science, but it also may be clinical trials, for example, and clinical research. It may be health outcomes research, a really burgeoning area at the moment of interest in medicine. How do we actually get the things we know, put them into the health service, and make outcomes for patients better? It may be implementation science, how to get good ideas and make them work. Medical education research, or a combination of all of those. A lot of us do more than one thing. Also important is a love of teaching, but not just teaching your craft, your skill, but also teaching scientific method, you know, how to understand the literature, develop a hypothesis, plan research, write manuscripts, give good presentations, and importantly, mentoring. The real importance you heard before of looking after the next generation of people, whether that's surgeons, in my case, or other doctors, or scientists. And what kind of teaching can you do? Well, again, you know, it's really important, obviously, to teach within the medical school and teach those around you, but also think outside the box. What about the community? You know, making sure the community understands good health literacy about your disease or whatever you're interested in, or teaching allied health people so you have a good team around you who really understand how to look at those patients. And all of you can do those things now, so have a think about that. Now, I'm not going to talk about the pathway to becoming a clinician scientist because there are lots of different pathways, and you'll hear about those today, and I think all of us have had a different one. Mine has certainly not been a particularly conventional one, and I think that's the same probably for quite a lot of surgeons and probably for more women than men as well to have a more unconventional pathway to becoming a clinician scientist. But I'm happy to talk about that in more detail with any of you individually if you ever want to come and see me and talk. Now, I had to get this little imposter syndrome monkey off my back a bit more because this is some good news here. This was a study from the United States where they looked at surgeon scientists. So this was clinician scientists who were surgeons, and they found that about 19% of faculty within surgical departments in the United States were women, but actually more than 19%, 26% were primary investigators on trials. So women were actually punching above their weight in getting grants, which was fantastic. They were more likely to be first-time grant recipients. And this little fact down at the bottom was really interesting. From departments where there was a female surgery chair and a high proportion of female faculty, women were much more likely to be successful in research. So maybe eventually that will become normalised and we won't all have to have that imposter syndrome of women on our back. I hope so. And I would encourage all of us to think about diversity, and it's certainly not just gender diversity, it's diversity across all aspects. It's really important for us to work with a bunch of diverse people. So I'm just going to talk for a little while now about some other aspects that you might want to think about as you pursue your career as a clinician scientist. And John mentioned a bit about this, and I will go on about it a bit as well. That road from discovery to practice, of getting your idea that you've got for research into practice to actually affect patient care, is a very long and winding one. And from where you're sitting, you know, as a junior doctor or working in a lab, that can almost seem an impossible task. And of course, just because your discovery is fantastic, it doesn't mean it'll become clinical practice. In fact, only a very small proportion of really good ideas do eventually become clinical practice. You heard about John's story of that really good drug which was too toxic in the end to use, at least in that condition. And it takes a long time. And you have to be prepared for that long wait. I'll show you a little paper in a second where it suggests that it takes 17 years to turn research into patient care. And looking back on my career, 17 years is about right for good ideas to eventually hit clinical practice. And discovery is vital, but there's also this idea of the implementation pull, which I'm glad Helena is here because I think that might be your word, isn't it? And hopefully you'll be talking about that a bit more as well. But that's the idea that, you know, you can do lots of good research, but as clinicians, we ought to listen to what's needed out there and maybe tailor what we're doing to the actual clinical needs of our patients around us. So I hope you'll hear more about that later. And this was a paper showing this 17-year odyssey, which sometimes it's longer, sometimes it's shorter. You might have a great idea that's so good that, you know, you discover penicillin and suddenly everybody wants to use it, but it's unlikely. It will be a little incremental things which will all add up. And eventually you'll go, wow, that little idea, that's actually starting to, you can see that's being used. You know, I went to my GP and that little idea was actually being used now. So hopefully you'll all see that in your lifetimes. I also wanted you to think a little bit about this idea that I think is really important, that research is great, but when we think about research, we also need to think about the long game. So think about, if you've got a good research idea, how eventually is that going to be implemented and put into practice? Or is it so impracticable that it never could be? Have a think about the other bigger things around that that will make that thing work in practice. And that may be how we affect policy. Now you guys think, well, how can I affect policy? But eventually you will be affecting policy. You'll be advising government. You'll be sitting on committees that decide which drugs get funded or which procedures get funded. And behaviour change is really important as well, how we actually use the discoveries that we've made in clinical practice. So I was going to give you a few examples of some research that I've done over the years which might illustrate some of those ideas. So I'm a breast surgeon, but I'm very interested in imaging of the breast. And I'm sure you've all heard of MRIs, and MRI is probably the best test we currently have to image breasts and breast cancer. And lots of guidelines around the world suggest that we should have MRIs. And yet in this country, MRIs were not funded. For years and years, they were not funded for breast. And about 20% of women with newly diagnosed breast cancer, their doctors would suggest them they needed an MRI and they'd have to go and pay $2,000, $3,000 to have one done. Clearly a very inequitous kind of thing. So we kept going to government and we kept saying, why won't you fund this? They went, oh, there's not enough evidence, and there's not enough evidence in Australia that this is of any benefit to the patient and is going to change their pathways. I got very upset about this, so eventually I said, well, we've got this new fund called the Medical Research Futures Fund, and there's a bit of money in it. How about you work out what we need as government to fund MRI, and you run a study to try and prove to us in government that this is going to be useful? And they said, what you need to do is you need to prove that MRI improves therapeutic efficacy, i.e. it changes the clinical management pathway in some way, and that it's effective, that it improves patient outcomes. You need to show things like patient-reported outcomes. What do patients think about it? You need to tell us whether it affects surgical planning, disease recurrence, and most importantly, is it going to save us money, or at least is it not going to cost government too much money? So we thought, right, we'll try and put all this together. So we designed a trial to do just that, and this trial finished recruitment last week. So I can't give you any results yet, but I've had a quick, dirty look at the data, and it looks like we may be able to go back to government and say, absolutely yes, this trial has proved exactly all those things that you want to do. So we designed a study to get this thing licensed and paid for so women could benefit from it. So not a kind of novel idea, but a way of doing implementation research. So was this just research? No, it wasn't. I think it included implementation, practice change, policy change, and now we're going to have to educate doctors as well when to use this technology. It can't be used on everybody. There's lots of downsides. So that's the behavior change that we're going to have to do now. Another example of some research that I was involved with for many years was this idea of partial breast irradiation. And this is a sort of cautionary tale, I guess, because a little bit like John's tale of a new drug that didn't in the end work because of toxicity, this was some research that perhaps hasn't worked as well as we'd liked. So the idea with this is in breast cancer, if you have a lumpectomy, which about 70% of women with breast cancer have, generally we give whole breast irradiation afterwards. We irradiate the whole breast. And yet we know that if we have a look at cadaveric specimens of breasts after breast cancer, there's often little foci of cancer cells around the breast. But in fact, if you look at recurrence, almost all recurrences will occur in the index quadrant. So there we are, removing the breast cancer, irradiating the whole breast, and yet why are we irradiating the whole breast if most recurrences occur just around where the tumour was? And in fact, if we're irradiating the whole of one breast, why don't we irradiate the other breast as well? You know, what's the sense in that, you may say? So we thought, well, for selected patients, maybe we can just offer partial breast irradiation, and there are lots of advantages to that. It's quicker, it's cheaper for the system, it's better for the patients, got better outcomes, and it can all be done at the same time. And we developed this technique where it was actually given all during the same operation. So the patient would come in, they'd have a lumpectomy, they'd have their radiotherapy at the same time, take about an extra half an hour in the operating theatre, they'd go home, end of their cancer treatment. They might need to take some medication. This is for good outlook breast cancers. Patients loved this. It seemed to make complete sense. We put this to government. We did a big study. It's called the Target Study. This time we had 3,500 patients within a study, 35 centres around the world. We showed that survival was the same. Local recurrence fell within our equivalence limits. Seemed to be a really good idea. Took it to government, got a Medicare item number, and yet it's only practiced in 3 centres in this country. You say, why is that? Well, I think it's because there's lots of reasons of things that don't always make it into practice. You know, there's things around money. The item number that was given by government wasn't enough, so radiation oncologists are more happy to use whole breast irradiation, which pays better. There was clashes between personalities. Disruptive technology. You know, people don't like disruptive technology. They like, you know, as doctors tend to like what we like doing and don't really like to disrupt things. And I think we didn't think through the whole life cycle of how to implement something. So it's just a cautionary tale to tell you just because something's a really good idea doesn't necessarily mean that it'll end up going into practice. Another area I'm interested in medicine is in breast cancer, or in all cancers, is survivorship and really improving, allowing patients to thrive after they've had cancer, not just survive, but get back to a new normal and get healthy and get fit again. And we've done lots of research around this showing that exercise can actually improve survival after breast cancer. We've done work around treating menopause symptoms, and exercise can help that, as can lifestyle changes. Big national study on healthy living after cancer. But of course, adopting this is hard. You know, patients they just want to take a pill. They don't necessarily, you know, a 60-year-old woman with breast cancer who's just been through surgery and chemotherapy and radiotherapy, you tell her she's got to go to the gym and get fit. It's like, really? You know, can't I just have a pill to do that and lose weight? And also, there's no Medicare item number. The government don't pay for you to go and do your exercise. So there's lots of barriers to doing things that you might think is a good idea. And just to finally think, another area of research I'm interested in, and John mentioned industry, he mentioned pharma. Of course, as a surgeon, we're often involved not with pharma, but with other things such as engineers and material engineers. And I became involved with some optical physicists for many years at University of Western Australia. And working with a fantastic multidisciplinary group of people, we developed this idea of something called optical microelastography, so looking at the optical stiffness of tumours at a microscopic level. And we set up a company called OncoRes. We did some trials, and what we were able to show is with our little probes, we could tell after we'd removed a tumour, we can tell at a microscopic level if there's any tumour left behind in the cavity, in a breast cavity afterwards. So this was a really exciting development. The company is now going from strength to strength. It's actually just raised $17 million in Series B round, so I'm kind of trying to learn all this commercialization thing. FDA breakthrough approval, and we're now looking to develop a clinical trial and perhaps, you know, this could be the idea of this technology is if you've had your lumpectomy and you've had your breast cancer removed, the surgeon can use a little probe and make sure there's nothing left behind. Because we know about 20% of women have to go back and have a second operation because we're worried there's something left behind. So the idea of commercializing things and actually not being afraid to go to industry and take things to industry and understand a whole different way of doing research, I think is a good one. And again, this is not reliant just on research. You know, we'll need to now think about regulatory issues. We'll need to think about the implementation and practice change, the price points for these kind of things. And behaviour change. You know, surgeons now need to use a different tool in theatres every time they do an operation. How do they learn to do that? But I have to say, in much this, as in much research, I think it's going to be patients who are our best advocates. Because if you're a woman with breast cancer and somebody could say to you, well, we've got this tool which will tell us with 97% accuracy there's nothing left behind in the breast, that cost a couple of extra $100 to use, or we could just guess that everything's come out. What would you prefer? Now, clearly you would prefer to know. So having patients advocating within that research setting is also important, and designing the studies using patients and having what they think is important as endpoints is really important in research. So I'm going to finish up shortly, but I just wanted to leave you with these thoughts that there are lots of different kinds of clinician scientists, and all of us, everybody you'll hear from today is different and has had a different pathway. But I think most of us will share common features, you know, asking the questions and working out how to answer them, as opposed to just asking them and reading other people's research. Being an innovator, but learning how to put that into practice. Being an expert, being really good in one area. Importantly, disseminating that knowledge and training the next generation. And being a leader. You know, you're all going to become leaders in your fields into the future. But also remember that not all good research does make it into clinical practice, and it takes a long time for it to do so. And that research, I think, you do need to think about an implementation plan, policy work, at least clinical research, an implementation plan, policy work, and even behaviour change, behaviour amongst patients, clinicians, health administrators, our funders, governments, to really change practice. And I think if you can do all of those hard yards, you're probably going to be a really successful clinician scientist. So thank you for listening to me. I'm not going to be able to be here all day because my daughter's just arrived from Europe, so I probably ought to spend some time with her, actually. I haven't seen her for a while. But you're more than welcome at any time to, you know, send me an email, come and see me. Love to talk to you about it, and we really need more surgeon scientists as well. So thank you.
Thanks, Christobel. That was wonderful. And I thought what I loved about that talk was how wide-ranging your comments and thoughts were about so many different aspects. And often these aspects don't even occur to you when you're a student, like policy change and behaviour change and government change. And I think they become evident as you go along your career, and I think this behaviour change with good science is a huge issue that we have to worry about. So let's open the floor for questions. Do we have any questions? Yes, thank you. There are two, one there and then, yeah, thank you.
Hi. Oh, sorry. Thank you very much for your talk. That was really interesting. You mentioned that there's a lot of different pathways to becoming a clinician scientist, and I have heard from a few that doing a master's in public health can be very beneficial. I just wanted to know what your perspective on that was.
Yeah, I think it is, and I think that reflects the fact that many clinician scientists are interested not so much in laboratory science but in public health, epidemiology, those areas. And I think an MPH does teach you some really good research methods, and you'll also meet a lot of really interesting people who you can end up working with. So coming to the University of Melbourne has been fantastic because there are great people in public health here who I've been able to connect with, in implementation science, and people who understand some of the big data issues as well. So it's probably a nice broad thing to do, and I reckon it wouldn't be a bad idea. Yeah.
Yes,
Thank you.
please.
Thank you. So I'm a student at the University of Melbourne, and I help to run an organisation called Melbourne Bioinnovation Student Initiative. And so basically what we do is we partner medical students with science students, engineering students, commerce students to basically create student-led projects. What advice would you give us to better engage with the medical community and potentially medical students, not just in identifying areas of unmet need and innovating, but also working with people from different backgrounds in actually creating a solution? And you mentioned that you're working at OncoRes, where you're obviously working with people from all different skill sets. What can we sort of empower our project team members and the students who are part of our group to help them succeed?
Well, you're lucky at the University of Melbourne because you've just got a new Associate Dean of Innovation in Peter Chung, who is an Academy member, one of, I think, 8 or 9 surgeons only, Ingrid?
There aren't that many.
But Peter is one, and he's an orthopaedic and sarcoma surgeon and an incredible man and very passionate about exactly this area. There's also a lot of interest amongst diverse groups around the university, medical groups, in that kind of biomedical innovation. Ophthalmology is a fantastic example, where people really great work going on, ENT. So often some of the specialities that you wouldn't necessarily always think about as traditional research-orientated or academic disciplines have got some great stuff in that area. So as Melbourne medical students, I would suggest going to talk to Peter Chung, and he'd put you on the right track. And Monash, I'm sure there's something similar here.
And
yeah.
Deakin and all the other universities.
Our Deakin's got some fantastic stuff. They're doing they've got a really exciting lab of medicine in extreme environments and space stuff. And of course there's also I've got introduced Peter to a mate of mine who runs the Australian Space Agency. All sorts of really cool stuff going on there. So enormous exciting innovations.
We've had a few.
University of Queensland. I know there are people online for Queensland. Yes, sorry.
We've had a few chats with Peter already, and yeah, he's been really supportive. But it's great to sort of get more of a perspective on. There's so many different things, and it can be hard to reach out to mentors. And
well, the other thing I think today, talk to some of the institutes, because most of the institutes will have biomedical spin-offs, won't they? And they often are doing some really exciting things. So have a chat to the institutes as well, and they'll almost certainly have some good ideas.
Yeah, we have the Centre for Eye Research, so they'll be very hot on the eye area. And I think the research world's exploded with all this industry and commercialisation. It makes it a whole new level.
Yeah, just on one note on that, at OncoRes, we've just taken on a young surgeon in Perth, Arusha, on a Department of Industry fellowship to come in for a year, come out of her surgical training. So this is a different pathway to being a clinician scientist. She's come out of her surgical training and she's actually going to enter a commercial company for a year, help set up a clinical trial, learn all about that regulatory things, and then hopefully she's got a fellowship but hasn't done her post-fellowship training, hopefully go on to a career as a researcher.
Yeah, that's fantastic. And it goes back a bit to what we were talking about, industry and pharmaceutical areas, that they are your friends, not your foes. And certainly when we trained, they were the dark side, and now they're not the dark side. More questions? Yes, at the front here. We'll just wait for the mic. It's on its way. Thank you.
Thank you for your talk. It was very informative. Just on the point of on engaging with industry, from experience, how have you found industry's tolerance of the risk of putting large quantities of funding into a particular research project and coming up with negative results, like that the particular treatment doesn't work? And following on from that, how does it affect the types of proposals that we put through to industry for funding and testing?
I'm not sure I'm the best person to give you an answer to that, but I mean, I think industry must be the first to realise that not everything is going to work. That's why it costs so much to develop a drug. I mean, it costs billions to develop a drug, and that's because inevitably there must be lots and lots of blind alleys that they'll go down before eventually getting there. So I think, if anything, industry probably know about that better than the rest of us. And for the rest of us, it is a problem. If you end up going down a blind alley and you work in a department somewhere in a university and you're reliant on money from your various grants, and that you don't come up with a good, really exciting paper at the end of it, when you apply for your next grant, it could affect your career. That's probably more going to affect our scientists, sadly, than us as clinicians. We're fortunate that we can often pivot and use good ideas for something else. I don't know, Ingrid, do you have any comment?
No, I agree. I think it's a complex space and not straightforward. I have another question. How are we going to increase the surgeon scientists? Because I think that's a huge issue.
I think I agree with you, which is why I wanted to sort of push the barrel a bit today of the surgeon. It's not easy, and I wish I had an answer. We've fortunately, when I arrived in Australia in 2000, our College of Surgeons really thought that academic surgery was a bit on the nose, and there was a very common misconception here in Australia that to be a successful surgeon, you had to have a big private practice, nice fast car, all the rest of it. And when I arrived and said that I just wanted to be, an academic professor of surgery, I thought that was the pinnacle of being the best thing you could do. I was looked upon with some scorn. Truly. I think that's changed, and our college is now really getting on board with lots of scholarships, lots of grants. We've got a very active academic surgical section and society, so we'll have our meeting in November in Sydney, very popular. We have a fabulous thing called Developing a Career in Academic Surgery Day at our college meeting each year, which if any of you are interested in, I would strongly recommend going. It'll be next May. Next year it'll be Brisbane, I think. Really good program. So we're doing our best to encourage it. I think that things like the MAC track program that John's just been talking about, we've just got our first application from a surgeon, which we were reviewing this week. I don't know if he'll get up yet, but it's great to see that. So I think it's always that combination of, role models, encouragement, having a pathway, and maybe doing it at the right time. Surgeons have probably more difficulty working out when to come out and do their research, and there's this kind of idea that if you put down the tools for a year or two, you'll forget how, or you'll move on, or everybody will forget about you. So having a pathway that surgeons can still do, some operating, whether that's private assisting or on call, and having some good clinician mentors is important.
Do you think that's true about forgetting? I always wonder how valid that is. If you don't operate for a year, it's like...
No, I don't think it's true.
Yeah, so there's quite a bit of mythology still to dispel, and I think it's an attitudinal shift, which is happening, but as you said, there are only 8 surgical fellows in the academy.
So the other thing is, I think having more women, I know that sounds a cliche, but I think it's true. There's some great younger women coming through doing academic surgery now, whereas before it was seen as a real the last bastion of male medicine.
But the problem is a little bit, I think, for women that they have this question of how do I do clinical work, research, and have a family, and work part-time and do it all. And believe me, you can. So let me just start with that. But you just have to be very organised and compartmentalised so that you have your research time, you have your clinical time. I can't say I've ever done that well. And then you have your family time. But you can do it. But I think that has scared women off, don't you?
I think it has, yeah. Yeah, and just because, you know, that picture I showed you, that old man with all the diplomas behind him, that was what people thought academic surgery was like, and it probably was. It's not anymore.
All right, have we got any more questions? Well, last question over there, thanks.
Surgery is also like already quite a demanding profession in itself. Do you find it hard to balance surgery and do research simultaneously, or do you just do one at a time?
Personally, I don't. I mean, I love it. You know, I love it. I mean, I love looking after patients. Inevitably, you know, that time face-to-face with patients is great, and getting to the operating theatre is a kind of this lovely little bubble that nobody can bother you. But for me, you know, the passion of finding out new things is so good. And I think I can contribute more to both the patient in front of me, but also all of the patients, you know, and having that ability to do it. If you're fired with it, and you can make anything work, can't you?
Well, I think you've really inspired us about becoming surgeon scientists. So please join me in thanking Christobel and for giving up a morning.